Okay, good. Can we then? Hello, everyone. Hi, Mohammed. Can we start with your presentation? Then I just introduced you.
Great, thank you.
Okay.
Good morning. I would like to thank the organizing committee for giving me the chance to present our ECMO experience from post-congenital and heart failure unit perspective. The concept of ECMO, to me, has always been like a ticking time bomb. You need to defuse it as soon as possible. However, working in a unit that deals with heart failure and transplant, I realized that you don't need W07 to defuse it. You simply need knowledge and experience. And the impact of experience is evident when you look at the ECMO results of the ELSO registry, with overall survival over 50%. This becomes slightly better when you look at large volume units with more than 20 ECMO runs per year. But it's more evident when you look at the unit that started the program in 1994 with over 30 ECMO runs per year. In heart failure unit, results are significantly better, as the case with Newcastle. In our unit, we deal with our local patients as well as those referred to us from other centers. And in this presentation, I'm going to briefly touch on postcardiotomy patients, elaborate more on ECMO for heart failure patients, discuss some of the challenges we face, and present a couple of cases. ECMO for postcardiotomy patient is usually a bridge to recovery. Patient with acceptable function going through a routine cardiac surgery would, in most times, require ECMO if there's a missed residual lesion. And there is a strong evidence that if you correct those lesions, you'd be able to wean ECMO easily and safely. When we looked into our own experience, although we couldn't prove that free intervention was a prognostic factor, it became clear that the longer the ECMO duration, the poor the outcome is, with weaning chances halved that after 7 days, and the odds of death tripled after 2 weeks. As a result of this, we came out with some guidelines to our postcardiotomy ECMO practice. So it's now our routine to have some imaging by day 1, correct any residual lesion and attempt weaning on the same setting by day 3. And if no residual lesion found, then levosimendan is given and recovery is expected by day 5 to day 7. If we failed wean by day 7, then VAD should be considered. When it comes to heart failure, ECMO is a quick and easy deployed option that is good to resuscitate the patient and improve end-organ perfusion. And in those patients, unless it's an acute myocarditis, ECMO is not considered as a bridge to recovery. It could be either a bridge to candidacy decision, a bridge to a longer-term support, as with VAD, or for the lucky ones, a bridge to transplant. And I say the lucky ones because it's no-brainer that waiting time for heart transplant is much, much longer than what ECMO can offer. This benchmark trial has stated the obvious difference between ECMO and ventricular assist device when it comes to duration of support and transplant waiting game. So the first challenge we have with ECMO is the duration. ECMO expires quickly, and that was evident when we looked into those patients who were referred to our center on ECMO during a 10 years period of time. In those 22 patients, the average duration of support was 12 days, ranging between 4 and 19. Those referred late here spent less time with us. We were under pressure to convert them to have VAD support, and unfortunately didn't have the best outcome. An example of time pressure is this child. She was operated for supravalvular aortic stenosis and failed to wean off cardiopulmonary bypass and went on ECMO for a few days. She managed to limp off ECMO, but a couple of days afterward, she crashed back into ECMO. It was a long run at the referring center, with investigation failed to detect any residual lesion. We received her late, and we looked at her angio with a fresh pair of eyes, and we could see a suspicious of left main coronary problem. We took her to theater, and we tried to get inside her chest, but she was in such a coagulopathy state after a long run of ECMO and with open chest that we thought this child has only one chance and transplant might be her best option. Because of her weight, she was one of the lucky ones, and she had a transplant the next day, and it went successfully. That's her heart that we examined after explant. She had an isolated left coronary artery, something that we might have addressed if we received her earlier. Another challenge we have with heart failure patient is LV distension. We all know that ECMO is good when it comes to RV decompression, but a failing left ventricle will not withstand the afterload caused by ECMO flow. It will stop ejecting, distend, and build back pressure on the lungs, which subsequently will develop congestion, consolidation, hemorrhage, and end up with significant lung damage that may preclude any chance of recovery or transplant. Here's an example of a child with cardiomyopathy who collapsed. An ECBR was achieved through neck cannulation. The LV got distended, and the X-ray showed white lines. Although HL stent was attempted at the referring center, this has failed to improve the situation. There are different strategies to decompress a distended left ventricle. Either a surgically placed vent, as in this case here, a transapical vent, or a transcaster vent replacement, or transcaster septostomy, or intra-atrial stent placement. Also, intra-aortic balloon pump can help in older kids, and to some extent, medical manipulation of afterload and inotrope can achieve similar results. Let's get back to our case. When we receive the child, knowing that he's heading towards VAD, if we manage to salvage those lungs, we place a central vent that saves the lung and lungs has recovered. Later, this child went to have a BiVAD support of both right and left ventricle. But because we were still worried about the lungs, an oxygenator was added to the RVAD circuit for a few days. This is an example of how ECMO can be adjunct to VAD. We have used this and other similar configuration as a combination of different mechanical circulatory support options, and the outcome was not different from those supported with a single modality, as you can see in that article we published back in 2015. As regard to our experience with ECMO post-heart transplant, over a quarter of our patients required ECMO post-transplant. This is a relatively high percentage when compared to other units. The reason for this is that we tend to accept high-risk donor hearts, which made up to 70% of our donor cohort. Also, we had a similar percentage of our recipients in the high-risk category. The outcome of our study has confirmed again the importance of duration on ECMO as a prognostic factor, with no survivor with longer than 2 weeks ECMO run. The survival of patients who required ECMO post-cardiac transplant is significantly worse than those who didn't. This difference is mainly shown in the immediate post-transplant period. After that, the curve flattens. On the other hand, those results are very good when you consider that ECMO is offered to those with graft failure who wouldn't otherwise survive. As we all agree, ECMO is a whole unit teamwork, but it starts with a surgical placement of cannulas. And here comes another challenge for the surgeon to answer this time, the cannulation approach. Many factors play when the best cannulation strategy is in question. Mode of presentation is important, whether it's failure to wean from cardiopulmonary bypass, and in this situation, central cannulation is the most straightforward option. Some may prefer, however, switching to peripheral cannulation to avoid open chest and bleeding and infection risk. In ECPR, the quickest is the peripheral access, while in semi-elective situations, all options to be considered. Age plays a role as well. We tend to avoid neck cannulation in those over 2 years of age to avoid any chance of massive stroke, as collateral circulation in older kids cannot be trusted. When it comes to patients with congenital heart disease, knowing the available peripheral access as well as the cardiac anatomy is essential. In Fontan, for example, you might start with peripheral cannulation. However, you need to get into the chest and decompress the common atrium, the left atrium, as soon as possible because of the huge collateral load on those patients. There's no doubt that surgical experience with ECMO has developed over the years, and we no longer see those photos of messy ECMO. It's rather the neat, clean ECMO setup that become part of our daily practice, whether it's a central cannulation as in this picture or a peripheral cannulation of the femoral artery with a graft as in this photo. To conclude, ECMO is still a ticking bomb with loads of disadvantages, but having an intensive care unit that know how to defuse the ECMO time bomb is as vital as having this man in Liverpool defense. Thank you.
That's love.
No, unfortunately, we don't have the money for him.
Maybe he doesn't like these black and white colors.
Could be.
Yeah. Okay, so thank you very much, Mikhail, for a very nice talk. So I would just I think it's the best way to move forward is continue with the team's presentation, and I would really encourage all participants to put their questions, and then we can answer on those questions later on when we finish a second presentation, if you agree. So our second presenter will be Tim Jones, the cardiac surgeon from Birmingham Hospital. So yeah, hi Tim.
Hi.
Okay.
Great. Well, thanks for the invitation. I think in the interest of time, let's run the video.
Hello, my name is Tim Jones. I'm a congenital cardiac surgeon at Birmingham Children's Hospital. Ref has asked me to talk about the ECMO service and the role of the cardiac surgeon from a congenital cardiac centre point of view. Now, I've got no disclosures for this talk, but it's quite interesting because what I really want to do is to go back and look a little bit about the evolution of the ECMO debate, because over many years we have spent our time at the society meeting, first of all deliberating should we or should we not have an ECMO service in every cardiac centre. I initially came from a centre, of course, where we did not have ECMO and were quite strongly saying we didn't need ECMO, but now here we are with quite an active and large ECMO programme. We've also debated whether we should have wet prime circuits, dry prime circuits. I know that when Andrew was arranging the meeting, we had some excellent discussions about the role of ECMO. And I think Lars and I did a pro-con debate another year. Even go back to 2009, all this was happening. So now here we are, some years on, discussing what's the role of the surgeon in ECMO. So have we gone beyond the question is, should all centres have an ECMO service? Well, I think we have, and it's quite interesting that ECMO is now being embraced around the world. And why is that? Well, we know that as we've got better at looking after children with congenital heart disease, the mortality has come down. As the mortality has come down, so the expectation has gone up significantly. We're able to do much more complex surgery, early primary neonatal repair and reconstruction. We know at times can be physiologically challenging, and what we need is an ability to sometimes support the heart post-operatively. Now, that's what we wanted as cardiac surgeons, but of course the ECMO community have been supporting the lungs for a long period of time, from 1972 and Hill's first ECMO success with an young adult with ARDS. So expectations have gone up, technology's gone up, mortality's come down. The role for ECMO to help children recover in the post-operative period. At the same time, if we take this picture, I think this is from GOS back in the 1990s, where you can see the ECMO circuit was hugely complex. Really, it was the service done by the absolute committed, whereas nowadays, following new pump technology, second generation centrifugal pumps, and an entire slimming down the circuit, we can see it's very reproducible, it's much more fail-safe, and can be delivered much more rapidly and almost with less supervision than we used to have to back in the 1990s. So an evolution of the equipment has allowed much more widespread dissemination and uptake of ECMO services. Also in the United Kingdom, of course, there's been some quite powerful legislation come out. The National Institute for Clinical Excellence back in 2004 looked at the available evidence and deemed that ECMO may be used following heart surgery in post-neonatal children to ease the transition from cardiopulmonary bypass. So they looked at the evidence available and said that yes, this was a sensible thing to do, and there was evidence to support it. And if we move on over the years, obviously there's the congenital heart disease standards come out as safe and sustainable, and we can see back in 2013, 2014, the NHS standards coming out that a pediatric cardiac surgical centre must possess electrophysiology, echocardiography, cath labs, intra-op echo, TOEs, MRI, CT, and post-operative extracorporeal life support. So it now is one of the standards for all units undertaking congenital cardiac surgery on children in the United Kingdom. So we've seen there's been a wide uptake of ECMO, and the debate has moved on from should we or shouldn't we have it. It's now as to how should we have it. And in fact, this has been mirrored around the world, and this is data that comes out from the ELSO organization. The little logo's behind my head there. But what we've got here is we've got neonatal runs, and we can see from, this is 2000, midpoint of this graph, from 2000 there's been an expansion in neonatal cardiac runs, there's been an expansion in cardiac runs in infants, we're seeing the same in children, and a delayed but much more rapid expansion in the use of ECMO in adults. So why are congenital cardiac centres using ECMO? Well, we can look at the ELSO data. They drill down in massive detail, and it's quite interesting sometimes to do this. Unfortunately, the color coding they use and the detail is too much on this to be able to see, so I've summarized it for you. And what we know in cardiac surgical centers and the indications in children for cardiac support, so VA cardiac support, in neonates and infants in the first year of life, is for the management of congenital heart defects. And this is primarily postcardiotomy support for the recovery of the heart that's been operated upon. Now, when you get into children, you see between the ages of 1 and 16, yes, the congenital defects and their management are still the predominant group, but we're now seeing cardiomyopathy coming in and myocarditis coming in as key indicators for support. And of course, when we get into the adults, down at the bottom here, we can see that cardiogenic shock following ischemic heart disease and cardiomyopathy are the primary indicators for ECMO. So we can see a change, an evolution in the indications over time. Now, interestingly, ECPR, so extracorporeal pulmonary resuscitation, this being you're having active basic life support, cardiac massage when you put on ECMO. When we set up the services back in the late 2000s, really, the outcome was very poor and was believed to be very poor, with survival less than 10% in some series. So a lot of cardiac centres said, we're not going to do cardiopulmonary resuscitation onto ECMO because the outcome is very bleak. But actually, this has been one of the real surprises in the last 10, 20 years of ECMO. And we've seen that in children, the survival is comparable to children who go on ECMO with active cardiac output. And we can see there's been a massive expansion. Again, going back to, you can see before 2000, it was almost non-existent. And we can see over the years a rapid expansion in neonatal runs and pediatric runs in children who are receiving active cardiac massage when they go on to ECMO. Now, this is probably the only real group telling us about survival advantage, because these children otherwise would have been dead, because it was prolonged resuscitation with failure to return cardiac output is the definition of ECPR. And so we have stopped prior to 2000. So here we've got a group of children who now are going on to ECMO, and we'll come on to look see what the results are. Now, initially, ECMO was done for respiratory support, and of course the wide expansion was for neonatal respiratory support, for meconium aspiration and the management of primary pulmonary hypertension, also much smaller numbers for congenital diaphragmatic hernias. What we've seen is that as obstetric care has improved, we're seeing less meconium aspirations, and as intensive care management has improved, we're seeing better management of primary pulmonary hypertension, avoiding the use of ECMO. So what we're seeing in respiratory support is there's been a decline, but it's remained fairly constant now, representing those two improvements in care. But when we look in the pediatric population, the over 1 year olds here, or the over 28 days, sorry, in this graph, we can see that again, from the late 2000s, a big increase in indications, and this really comes on the back of the adult data showing the benefits for pneumonia and various infections that benefit from support on ECMO. So we're seeing an expansion in pediatric respiratory support as opposed to the neonates. Now, with expansion in all this support, does it actually help? What's the sort of the survival numbers? Well, you can see here, this is ELSO data looking at the last 10 years around the world. And if we look at the neonates here, the pediatric patients, and I've highlighted the cardiac and the ECPR group, you can see that in neonates, about a 50% survival, and just slightly less if you're going on with active cardiopulmonary resuscitation. And in children, those numbers a little bit better for ECMO support and for ECPR. Interestingly, in the adults, this group down here, of course, ECPR only 29% survival, really reflecting how the adult doesn't tolerate periods of ischemia. And obviously, we're not able to gain such rapid metabolic suppression in the adults. So we can see that, yes, over half the patients we put on are surviving. There's always this age-old question, though, is, well, yeah, it doesn't matter whether you put them on or not, they still would have survived, or they still wouldn't have survived. And of course, ECPR is the opposite of that argument, because those children would have been dead. And actually, when we set up our service, we went back and looked at these numbers, and pre the ECLS service, which we started in 2008 as a congenital cardiac centre, we took almost 1,400 cases, and we had an overall mortality, all-comer mortality of 4.6% then. We put the ECMO service in place, and what I did is I case matched the next 1,400 cases to the preceding 1356. And what we found is that the mortality dropped to 3.3%. Now you'd say, yes, everyone's mortality has come down over that period of time, whether you've got an ECMO centre or not. However, what I did is I assumed the patients who had survived having had ECMO, let's assume they're now dead. And if you put those back into the calculation, you come back approaching the 4.6%. So in our hands, it did seem to have a stepwise improvement in overall survival. Now, this is a slide I use from our in-house ECMO course. And I always say that ECMO and ECLS is not a form of treatment. So why on earth are we doing it? And why in a congenital cardiac centre would we want to do it? Well, there are three goals of the support, okay? We are allowing recovery of potentially reversible causes of cardiac and/or respiratory failure. Enabling surgical correction of anatomical problems, obviously the very sick obstructed TAPVD, excellent. We can stabilize the patient before we get them to theatre. The obstructed mitral mechanical valve that comes in, we can stabilize the patient on ECMO before we go to theatre. But also increasingly a bridge to longer term therapy, either to a bridge being a VAD or to transplantation. Obviously, the other talk in this session is going to cover that in a lot more detail. And that is really what we're dependent upon, because if we're not getting our patients off ECMO, we've got to good close links with our transplant centre to see if they can help. And clearly, sometimes they do get inundated. I'm sure we'll be hearing more about that. Now, the other thing I just want to concentrate on really is this slightly odd arrangement in the United Kingdom about cardiac support and respiratory support, because as cardiac surgeons, we all want to offer cardiac support, but sometimes some of us get slightly less interested about offering respiratory support. Now, there's an anomaly here. If a patient goes onto ECMO for cardiac support, then the funding comes with the patient. If a patient, though, goes on to ECMO for respiratory support, that funding comes to the specialised commissioners, and that comes from an essentially commissioned pot of money. Now, this is why we've got this phenomenon of the lead and non-lead centres, because in cardiac support, anyone can put a patient on and you'll get paid for it. But in respiratory support, if you put a child on for respiratory support and you're not one of the designated lead centres, as they're called, for no other reason than I presume they were leading in this area in respiratory support, then you will not get paid. So if you're a lead centre, you get paid. If you're a non-lead centre and you put someone on for respiratory support, you won't get paid. Now, initially, there was Glasgow, Great Ormond Street, Glenfield, Newcastle as the main lead centres, and ourselves in Alderhay have joined them in recent years. And obviously the non-designated centres would remain Bristol, Evelina, Southampton and Leeds. Now, that's the current situation, but clearly there are ongoing discussions as to whether all centres should be providing cardiac and respiratory support, or whether we carry on in sort of a hub and spoke system as we're doing at the moment. And this was sort of part of the cardiac review that never really got resolved, and we're still waiting for a final outcome decision on it. As I said, back in 2010-11, there was a lot of need for paediatric respiratory support around the UK that swamped the 4 centres. So Alderhay and Birmingham Children's Hospital were recognised as surge centres, and over winter we were given the authority to back up the other 4 centres, and that happened over a progressive number of years, and ultimately in 2015 we were commissioned as national respiratory ECMO centres as well as cardiac ECMO centres, and we joined the other 4 to make up 6. Now, why am I talking about this? Well, because it's had an impact on our service, it's had an impact on our unit. We know the intensive care units have got finite resource, and we know it's a very populated and overused resource nationally. And so what we find here is when we were designated in 2015, this was an erroneous year. In 2014, I think we were bailing out a lot on respiratory surge, but we used to do between 0 and 1 respiratory supports a year. Now we're doing between 6 and 8, and even up to 10 respiratory supports a year. They're much longer than cardiac supports, and obviously that has an impact on the use of ITU facilities and ECMO facilities, and the whole debate swings around what's the role of the cardiac surgeon in all that. Should they separate into a respiratory ECMO and a cardiac ECMO? Well, I don't think that is the way forward, and I'll go on to explain why. If we look at ECMO, we're offering cardiac support and we're offering respiratory support, and predominantly as cardiac surgeons we're interested in cardiac support, but the two clearly overlap, and I don't think you can disjoint either of those two relationships. You run an ECMO service and it should have the capability of delivering cardiac support and respiratory support together or as 2 individual modalities. Now, why do I say that? Well, here's the ECMO patient, and clearly it isn't down to the intensivists, it isn't down to perfusion, it isn't down to surgery, it isn't down to respiratory medicine, it isn't down to physiotherapy, anesthesia, as to getting the best outcome for that patient. It's everyone working together. It is a team approach to get the best outcome for the patient. Now, What's the role of the surgeon then? Does the surgeon just sit back, and does the surgeon become just a pure cannulating service and ECMO becomes entirely under the domain of the intensive care unit? Well, no, I don't think so. I think the surgeon is an absolute integral part of the team, and it is a multidisciplinary team, rather like an orchestra made up of various different components, and depending upon what tune we're going to play today, whether it's predominantly respiratory support, predominantly cardiac support, CDH support, then we're going to use the key parts of our orchestra to deliver the best care we've got. And the surgeons are very much a significant part of that orchestra, not just for cannulation. We must never forget we have an incredibly good working knowledge of mechanical circulatory support, as well as for cardiorespiratory physiology and pathology. And those are the things that you need to run a successful ECMO service. We also, day to day, revolve our lives around anticoagulation and hemostasis in the operating room. And by the nature of the work we do, we tend to have leadership skills, particularly around the time of crisis, and particularly around the time of bringing a team together to achieve an endpoint or goal. We also are involved a lot in education, in surgery and training, and we should bring those skills also into the ECMO service. And if I look now at Birmingham Children's Hospital, I was quite instrumental in the setting up of the ECMO service there. And I was very keen that what we did is we set it up as a multidisciplinary service. And this is our model of care. The surgical director, that's currently myself, a medical director who's an intensive care doctor, and our lead ECS coordinator, who's one of our intensive care nurses. So the three of us man the service together. We make the decisions together, and then we have a wider group of people who fit into that service, covering all the domains we've mentioned, including, of course, all the laboratories and support facilities across the hospital. Plus, we then involve the PICU nurses and medics who are non-ECMO trained, so they're aware of what's going on in the unit. We built the service on the back of the Guide to Good Practice in Clinical Perfusion because it is high-risk care. Half your patients will not survive even if you deliver the best care. You're under incredible scrutiny, and you've got to have a quality management framework. And we used, and I'd recommend everyone to base their mechanical circulatory support programs on that Guide to Good Clinical Practice. There's got to be standard operating procedures for all your ECMO runs, whether it be cardiac or respiratory. It has to be risk assessed. There's got to be good leadership, teamwork and communication, of which the surgeon is key, and training and education, and ongoing peer review and audit of results. So in summary, I believe all pediatric cardiac surgical centers should have 24/7 ECMO. It's a multidisciplinary team approach, and all centers should, I believe, be able to deliver cardiac and or respiratory support. You've got to develop your centers along structured models of service and delivery with benchmarking of results against national and international standards. We must have a close relationship with our transplant centers. There's no point putting a patient on who's non-transplantable if that's the only way out. You've got to have those discussions ongoing real time with the transplant center. And indeed, the surgeon is an integral member of the team. Thank you very much. Happy to take any questions.
For amazing, really good talk, which show actually the role of, very important role of ECMO, not only from historical perspective, but also the current role of ECMO, which I think is really quite important for our outcomes nowadays. So I would really encourage participants to ask questions. Meanwhile, I would like to ask a question about this, because the session is about the surgeon role in ECMO. For example, in our center, we've got a dedicated ECMO service, let's say, which is integral part of our service, but in some ways quite independent. And they cover mostly respiratory ECMO, but also they participate in postcardiac ECMO as well. So I would like to ask, what do you think about, because there are a few crucial moments when we decide about going on ECMO. The first one is operating theater. If we are not able to come on bypass, then usually this is the surgeon decision to go on ECMO. The second moment is semi-electively the ICU if we struggle with a patient who is in low cardiac output and a lot of inotropes, and actually we need to decide semi-electively whether to go on ECMO or not to support the patient. And the third moment might be like ECPR, that actually we are already too late, the patient crashed, and then we have to do active CPR and go on ECMO. So I would like to ask, I think that from my perspective, the role of surgeon is a little bit different. Although in theater we are like a team leader, and our usually we can make this decision easily, but as a part of multidisciplinary team in ICU, especially during ECPR, particularly if this happens, for example, 1 week after surgery or a few days after surgery, within the first 24 hours, then our role is a little bit in a way under question, and sometimes we need to make decision immediately within a few minutes or 10-15 minutes. And so I would like to ask Mohammed or Tim to answer, what do you think, who has to make final decision about indication going on ECMO, and who should, because at the end, it's I understand it's a team decision, but at the end, someone has to make this decision.
Okay, well, I'm happy to kick off with that. I think it's an interesting question, isn't it? And I would still, I'd go back to the model of care. I think the ECMO service needs to be a standalone entity, and I believe the ECMO service is then comprised of the multidisciplinary components, of which cardiac surgery must be well represented and have a significant proportion of representation in the ECMO service. Now, what then really becomes a situation is obviously the do you go on or don't you go on? Well, that's going to involve a referral, obviously not a formal referral, but you're going to have to refer that patient to the ECMO service. Now, the ECMO service, because by nature some of these decisions are very difficult, it isn't a one single individual decision. I think the operating surgeon in the operating room clearly has done the operation. They know the patient, they know the family, they know the anatomy and pathology and prognosis for that patient. And if they believe that there's reversible, they believe it's reversible, they'd obviously say to the ECMO service, these are all things I think we should be going on. And that would just be the ECMO service would validate that decision, or they may say, well, this is a hopeless case. You've been there for 2.5 days in theatre. You've cardioplegised the heart 10 times. It's a salvage operation anyway. We don't think this is a long-term goer, because sometimes the individual can get drawn into the case and not remain truly objective. So I think the multidisciplinary component is vital. And what I think the worst situation would be is that ECMO becomes divorced from cardiac surgery because the increase in respiratory management, and it takes on an entire entity separate and without representation or involvement of cardiac surgery perfusion, because they are key members to it. So that would be my view, is it's a standalone service. All players are represented in that standalone service on a flat hierarchy, and it isn't down to one individual. And often, Frank, as you know, when we have difficult decisions, even then we will call yourselves to say, look, what do you think about this from an ECMO point of view? We think we should go on. Do you think we should? And you'll say yes or no. And we'll even go outside the centre to validate some of these difficult decisions. The final thing I'd also say is, preoperatively, if you've got a high-risk case, it's often worth having that discussion in the cold light of day, whether you're going to go on to ECMO, particularly if transplantation, and obviously hand over to Mohammed in a moment, is a route. Then you've got to have that decision and discussion with a transplant centre before you go into the operating room, because there's no point trying to retrospectively decide what you're going to do. And it might be, and it's not uncommon, that we decide this patient, it would not be for ECMO post-operatively, and we'll talk to the family about that pre-operatively, and it goes on the consent form.
Thank you, Tim. Mohammed, have you got anything to add to this? Or
yes, I agree. So it's our that we decide from the beginning whether this patient is for ECMO or not. So as a rule of thumb, all our patients who are offered cardiac surgery are offered ECMO. has been stated before, either in the JCC before when the decision for surgery has been taken, or at the time of admission. It's when we have a complex case admitted to PICU, it is the usual, the first marking of the patient. Is this patient for ECPR? Is this patient for ECMO or not? Once you have a complex case and you have an idea of what the vascular access, how long would you take to get this patient on ECMO, or what's the outcome of this patient, would he be a transplant candidate or not, then you will make a decision whether this patient is from the start. If arrest takes place, yes, please call me after 5 minutes. If the heart doesn't return, call me in 5 minutes, and this patient for ECPR, or please don't wake me up, this patient is not for ECPR.
Okay, thank you very much. So that means that every single patient is for ECMO unless it has been stated before that it's not?
Yeah. Yes.
Okay.
Probably on e-record for us, it says whether this patient, on the electronic record, says whether this patient is for ECPR or not. Yeah.
Okay, we've got some question here that's but what about decision on timing of weaning? I presume this Osama asked this question also about the surgeon role, about the weaning process. So when it comes to weaning, is still surgeon has got some role, or it's more about intensivist and their decision making?
I think I'd say it's the same model. When the patient is on ECMO, they're managed by the ECMO service. And the ECMO service, again, comprising the various different multidisciplinary people, make that decision together. Because, say, weaning a patient who's been on for cardiac support, like I mentioned, the analogy of the orchestra, you're going to find that cardiac surgery, cardiology are going to have more of an active role in that. Do we need to re-image the circulation? Do we need to do anything else to try and get this patient off? Do we need to skip back one stage in the surgery, reconvert them back to, say, an arterial shunt from a CP shunt, those things, and that's going to be much more surgically led. If you have a respiratory patient, then predominantly we're going to be finding that the intensivists are taking more of an active role in that decision making. But both sides shouldn't be working in isolation to each other, because there is definite overlap. And obviously the cardiorespiratory interaction is what we all work with every single day.
I totally agree. We need to put in our mind as well that the weaning of ECMO, the decision of wean of ECMO, is more of an elective decision. The patient has been there for 3-4 days. It's not as urgent decisions that you have to make in an hour or so as in ECPR, as in, when putting a patient on ECMO. It's taking off ECMO is a more elective kind of decision, where MDT is. Yes.
Okay. Yeah, I completely agree. Thank you very much. So there is one more question, I think, for Rafa. It's what about non-cardiac patient, respiratory, CDH, sepsis, cannulation, but cardiac surgeon? What is the experience in USA and Europe? I think that, yeah. Okay, I think that the cardiac surgeon were involved in a cannulation process for all these patients. Especially in kids. So I can't see any further questions, and I think that we are approaching the end of our session. Actually, we are probably
levosimendan here.
Yeah, there is one. Sorry, probably I missed.
Just regular use of levosimendan. Yes, we regularly use.
Okay.
Most of the experience with levosimendan comes from the adult, and I think there are some meta-analysis that showed that using levosimendan in adults at time of on ECMO, it reduces the chance of ECMO failure of ECMO weaning. And there's a recent article that comes from Melbourne as well that has proven the same. So the use of levosimendan reduce the chances of failure ECMO wean.
Okay, thank you, Mohammed. So one more, I think, question. I from your presentation, Tim, I understood that you've got 24/7 dedicated team for ECPR. Does it mean that they are in hospital or they are just on call and then they come
and you know, for future organisers of the meeting, maybe that's the next debate we should be having. Should we all be having in-hospital permanent residents? No. What we do at the moment, we still have our cardiac registrars in the building up till sort of midnight, then goes home, but it's within 10 minutes to the hospital. But on every nursing shift, there is a ECLS specialist, a most likely coordinator. So the cardiac surgical consultant, perfusionist will be at home, as will be a backup ECLS specialist. But actually in the unit, there will be an ECLS trained nurse on every shift, at least one and usually more. And also our cardiac surgical registrar will be relatively immediately available. And so within that, obviously we're aiming to get on in half an hour if we can, but certainly in less than an hour. And when we first set up the ECPR service, the first patient we put on was actually a hypoplastic arch that was due to go back to the ward, was sitting up in his pajamas, having his milk, and arrested, hypovolemic, in some distress. We massaged him for 2 hours and put him on, and neurologically, that was many years ago, he's actually unbelievably intact. But we've worked hard over time to get the cannulation times all down to under an hour and nearer to half an hour if we can.
Okay, thanks. Yeah, this is also our experience. We usually manage to put the patient on ECMO within 1 hour. Also, we don't have all team in hospital. I presume that it's also in Newcastle, and I'm aware that in all centers across the country, that's actually the same. Even Great Ormond Street, they don't have all team within a hospital. Okay. Okay, thank you very much. I can't see any further questions. I would like to thank all participants and also Tim and Mohammed for a great talk. And I wish you a good day and see you. Okay.
Thanks a lot.
Bye.
Bye, everyone.
Bye.
Thanks, Branko.
Thanks.